What is up? Hello and welcome to episode 120 of Chairside Live. We've got a good episode for you today. In our case of the week, we have a dentist who, and I realize it's only mid to late October at this point, maybe November when this episode drops, as we say in the industry. But I think I've got a winner for the impression of the year and the crown of the year. And I'm not being my usual sarcastic self. It's actually a fantastic prep and a fantastic impression. And I want to show it off a little bit. And it's not mine, but it just looks great. And it's one of those things where the doctor pretty much did everything right. And so often we focus on what, somebody may, including myself, somebody may have done a little bit wrong here or here. But every once in a while, it's good to remind ourselves exactly what this is supposed to look like. In our clinician interview today, we're going to talk with Dr. Todd Morgan, a good friend of mine. In fact, we used to practice together for a while, and a dentist who is one of the country's leading authorities on snoring and obstructive sleep apnea. And in part one of my interview with Todd, he's going to share how he originally got involved with this type of dentistry and how his dad played into it, who was actually his first patient that he worked on before he even knew what kind of appliance to make. And he kind of makes a homemade appliance for his own father. And he shares a little bit about what his dad was like before and after utilizing this appliance. That was my introduction working with Todd down in Encinitas, California. That was my introduction to obstructive sleep apnea and being able to treat those patients. I'd really never seen it before because, like most dentists, I had little to no exposure in dental school, but I saw what a fantastic adjunct it can be to a restorative practice. Today, Todd's practice is probably about 60% sleep and 40% restorative. And I tell you what, in terms of work and bending over and prepping teeth and impressing teeth, I look at obstructive sleep apnea treatment as kind of thinking man's dentistry. And it really is, and it's a fun way to be able to practice. And it's patients who are more grateful than almost any other patients you will treat. You are, in essence, giving them their life back. But before we get to both of those, I did want to bring up something that I had mentioned on an earlier edition of Chairside Live. I brought up the concept of remakes and how much does a remake really cost a dentist. And so when I say remake, basically I'm talking about you seat a patient or your assistant does, takes the temporary off, tries the crown on, contacts are a little bit off, occlusion's a little off, she makes some adjustments. Maybe it just doesn't fit. The fit's off, margins are short, whatever it might be. And now at this point, you've got to come back in and maybe give the patient the bad news. You could be 15 to 20 minutes into this, and now you tell the patient, we need to take a new impression. This just doesn't fit. We're going to need to re-anesthetize at this point so we can pack cord, take another impression. And you can say, in all honesty to the patient, I want a crown that's going to be the best, fit perfectly or as close to perfect as we can get and last you a long time. And this one, we can maybe make it work, but I want to give you something better than that, like I would want in my own mouth. And it sounds great, but what's the cost of having that remake and having to take that new impression? So I threw that concept out there. And a friend of mine who's a dental practice management consultant wrote in with his answer, and I wanted to share with you what he had to say. So this response comes from Kerry Strain of Strain Consulting. Kerry's not only a friend of mine, but he was the consultant that I used while I still had my private practice. And Strain Consulting is up in Sacramento, California. And if you want more information on what Kerry does or want a free practice analysis, you can go to strain, straine.com. So strain, straine.com. You may find out, like I did, that there's literally tens of thousands, if not hundreds of thousands of dollars waiting in the charts on your walls, sitting there, just people who've had treatment recommendations without any kind of follow through. I can almost guarantee that you will see a significant increase in your production and collection if you get involved with a consulting program such as the one Kerry does. And he wrote to me, he said, when I asked about the overhead of having to redo a crown, he said, well, Mike, it's good to hear from you. It's really not the overhead that's killing the doctor, it's the opportunity cost. And the opportunity cost is defined as the amount of production that would have been generated in the time spent on the remake. So say the remake takes 45 minutes by the time you find out the crown's not going to fit and can't be made to fit. You anesthetize the patient, get a new impression, re-cement the temporary. Let's say that takes 45 minutes to an hour. The lost production of another crown that could have been prepped during that same time is at or over $1,000, and you just can't get that time back. He said not to mention the negative goodwill that's generated with the patient, which is also immeasurable when things didn't go right, but you just can't get that hour back to prep that $1,000 crown. You've lost the production for that hour. He said if you want to look at the actual overhead amount, most one doctor for operatory practice have this kind of overhead, an annual overhead of about $600,000. They work 200 days per year. So their overhead per day is $3,000, meaning that their overhead per hour is $375 per hour. So when you add that up, you can see it's really more the loss of the opportunity cost, not getting to prep that $1,000 of production and having that on the books, that is more significant than the $375 of overhead, but you certainly have to add that in as well. And that brings me to the point about taking a little extra time to make sure that you're using depth cuts, that you've reduced enough for Emax or Bruxer or whatever restoration, that you've done the two-chord technique or used a diode laser instead of just guessing at the impression to make sure you have a fantastic impression and a good prep like the one we're going to see in today's case of the week. When we see doctors here at Glidewell that have over 50% remakes, we wonder how they continue to be able to stay in practice when you see what kind of effect that would have on a practice. 50% remakes, that's crazy. For example, I practice here inside of the laboratory, and there's 800 technicians in the building that I work in, and I could use all of them if I needed to all pitch in on a certain case, even though that's never actually happened. But even practicing within the laboratory with all the advantages that gives me, my remake rate is about 6.5%. It goes back and forth kind of between 6 and 7% based on what we're doing. And so what that means is for every 100 crowns that come hand delivered to me by the technician, 94 of those roughly are going to go into place without any issues, maybe just a slight adjustment here or there and be done. And then 6 of those 100 crowns are going to need adjustments where they're going to have to be sent back to the technician for a reshade or they just don't fit for some reason. And that's fine. That's a great batting average, and I'm perfectly okay with that. 50% remakes would drive me absolutely insane, but 0% remakes are not the goal. There is no perfection when it comes to this. We've identified 63 steps from the time you prep a crown to when it's seated, and we're humans working on another human who likes to move while the impression's in their mouth, and the restoration's being fabricated by technicians and machines, but there's a human element there as well. We don't expect it to work perfectly all the time, so a 6% remake rate is healthy and fine. 0% remake dentists scare me because I don't think they have a quality control filter because everything for them goes into place somehow and gets cemented. That's scary. 50% remakes, that would drive me absolutely insane if it was always just like the flip of a coin whether or not this crown or bridge was going to fit, and that's a crazy way to practice dentistry too, but at least they have a quality control filter and they're not trying to jam all of it into place, but somehow they're still dealing with this 50% remake. And when you look at these numbers, how do you stay in business that way? And it's obviously very difficult to do. So thank you, Carrie, for writing in and giving us your kind of opinion, your expertise on this. It's not just the actual overhead, but the opportunity cost. Once that day's gone, you can't get that day back again. And you might think, well, I'll add an extra 1,000, next week with an extra prep. And yeah, you could have done that anyway, but you're never getting back what you could have done that day. And let's not forget about what the patient thinks about you in your office if there's a remake or God forbid, a couple on the same tooth trying to get this crown to fit. So that all comes into play. So thank you so much, Carrie. Appreciate you writing in and sharing some of your business expertise with us. And now let's go ahead and take a look at the case of the week. On this week's case of the week, I want to show you actually a really nice case. And as always, I folded the name over so you can't see who the doctor is. Although case is so nice, I should probably actually give him some publicity, but I won't mention his name because I don't want to embarrass Dr. Robbins, but it's an awesome case. A couple of things that I like about it, it's a Bruxer case, which is nice. Obviously, I'm a big fan of monolithic restorations. And the Vita Master 3D shade, loving it, Dr. Robbins. That's absolutely fantastic that you're using that 3D shades. I'm a big fan of the 3D shades and find that those shade tabs match the natural teeth much better than the Vita Classic shade guides. Let's take a look at the impression. First thing we notice, we've got a plastic impression tray. I'm kind of a fan of metal impression trays, but if you use a stiff enough material, you'll be okay. And as I try to compress this in the area where the prep is, it's pretty stiff. I can probably compress it a little bit, but I don't know that that happened while the patient was biting on it. Usually for there to be compression, you'll see the teeth coming in contact with the tray somewhere, or you'll see the tray coming in contact with the retromolar area, but it looks like it was a clean impression. In fact, if we hold it up to the light, we can see that all the unprepared teeth were just about in contact, save for the mesh that's in the tray. So we know the patient was all the way together, and it doesn't look like there was any impingement on the tray itself by the teeth or the soft tissue. So we're going to assume that patient came together. And, so in the end, really probably nothing wrong with that plastic tray. I just like the stiffer metal trays, probably personal preference. Let's take a look at the actual impression of the prep itself, and it's gorgeous. I mean, it just does not get any better than that. We can clearly see the margin defined 360 degrees around the tooth itself. We can see a tag of material, at least a 0.5 millimeter of material beyond the margin as well. And so there's going to be no doubt in the technician's mind where this margin ends and how to fashion the emergence profile of this restoration, because this little tag of material here is in fact an impression of the root structure of the tooth. So fantastic job with the impression. Let's take a look at the model, and you would expect it to look pretty darn nice, and it does in fact look pretty darn nice. In fact, I grabbed this when I saw it before it's even been dye trimmed, but it already looks like it's been dye trimmed because it's such a clean impression. So really it's just a matter of going in and taking away some of this stone that you see around here to expose the margin. So you can see how easy that's going to be to dye trim. In fact, if you had a dental technician on here on their very first day, this would be the case you would want to start with, because the better the impression we take, the more basic it is for them to be able to trim the dye, and the easier it is. You don't need advanced dye trimming skills until dentists start to send you less than ideal impressions. It's just a great looking prep too. We got 5 millimeters of height on the preparation, so this Bruxer crown can be cemented with a traditional crown and bridge cement. My choice would be the Ceramer cement from Doxa, because the dental advisor has shown that it actually chemically bonds to the Bruxer material. If we look at the bite, when we have the patient bite together, or have the model bite together, we can see we've got at least 2 millimeters of occlusal reduction there, and that's actually more than we need for Bruxer, but that's going to give us a Bruxer crown that's going to last for decades instead of years because of that reduction. So we've got a nice clean margin too. In fact, this is really kind of a universal prep. This will work for a PFM, this would work for a lava crown, this will work for an Emax crown, and this will certainly work for a Bruxer crown as well. In fact, since this is a Bruxer crown, if you wanted to be more conservative, Dr. Robbins could have prepped the feather edge margin, or could have just prepped the knife edge, or could have prepped a bevel. But this universal prep is fantastic. This is exactly what I like to show dentists as the ideal preparation. I use the reverse prep technique to get to this point. Today we have a guest with us, Dr. Todd Morgan from Encinitas, California. Welcome, Todd. And I brought Todd in because I want to talk to him about incorporating snoring and sleep apnea into the general dental practice. Todd and I had the opportunity to practice together for a number of years, and while I was there, I saw that about 50% of what Todd did was obstructive sleep apnea type treatment, in addition to the other 50% that was restorative dentistry. And as a restorative dentist myself, I noticed something. I noticed that the work he was doing on the sleep patients looked to be a lot easier, if you will, at least not as physically demanding as the restorative dentistry that he and I were doing together. So I wanted to bring him in and ask him some questions, because I get a lot of questions at my lectures and emails coming into me about, I'm interested in providing this type of service for my patients. What's the best way to get started? So again, welcome, Todd. Thank you so much for being here.
Thanks for having me here. Appreciate it.
When you and I practiced together, the sleep portion of the practice, I think, was about 50% of what you were doing. And this probably goes back about 10 to 12 years ago. Where is it now? Is it still 50-50 between sleep and restorative?
Yes, it is. It's still about 50-50. Both the dental practice and the sleep practice have grown. However, the dental practice, not as much nearly as the sleep practice. That's really taken off for me. So Even though it's about 50-50 in terms of the patients and appointments, really the sleep practice is a little more profitable for me
than the restorative practices. That's interesting. Now, when you went to dental school, were you exposed to any of this stuff? I know that when I went to school, this never came up. In fact, I didn't even know about it really until I met you. So how did you get into it? Was it something you were exposed to in school, or was it?
Absolutely not. I mean, just like you, I wasn't trained in this at all. I accidentally discovered, basically, heard about anecdotal reports of a gentleman, Dr. Mead in Albuquerque, that was making snore guards, and I wasn't busy. I hung out a shingle. I mean, I didn't buy a practice, so I started out a little bit slower than if you had bought a practice. And so I read a lot. I read every journal. I read everything and saw a little anecdotal report. And I went out and visited him, and he showed me what he did. And basically I looked at it, and it looked like two night guards glued together with a little insert that held them together. And I said, you know, I could do that. And my dad, who was a champion snorer, I think they call him stentorian snorer. I mean, you could hear him down the hall in the next house. The neighbors would call, you know, hey, roll him over. But I tried one on my dad, and it was so remarkable that he instantly stopped snoring. My mother was so worried. She sat up all night for several nights wondering if, you know, she was so used to the noise, she said she couldn't sleep anymore.
Right, she had to start a chainsaw now in the background just to fall asleep.
Yeah, but you know, I have 4 brothers, and we were always in trouble, and no sisters. Always in trouble, and he was like the authoritarian of the family. And we were all afraid of him, and he was this mean guy, and you know, all of a sudden he turned into this guy that was cool. He was nice, he wasn't grumpy anymore. And so the change in him with his snoring, but also the personality change, he was getting rest. And now he was a different man. And that was so incredible for me that I knew I was onto something.
And so when you first saw this appliance, you said you read an article in a journal that showed it?
I just read an anecdotal report of one patient that he had published, and thought, you know, my dad was snoring, and so I went and checked that out.
Is that really the thing that got you to go? Was
Yeah.
that you knew your dad had this condition and that you might be able to do something
Well,
about
I knew
that?
he snored, and
Right.
really they didn't talk about sleep apnea back then with oral appliances. This is 1988. And so I dabbled a little bit, and I used the skills I knew. Take a night guard, and we know how to fit splints,
Right.
and glue them together and put them in different places, and I did that for years and years, and treated more and more patients. And finally I took the idea to a sleep lab in San Diego called Scripps Clinic, and one of the docs said, hey, let's try some of them. I just had the right timing in the right place. And after that, we published some results on 20 patients with full sleep studies, and we were curing sleep apnea with these appliances.
And was this the first time, does this mark the beginning of oral appliances being used? I mean, traditionally, what did they do for patients with sleep apnea?
Oh, they've always used what's called CPAP, continuous positive airway pressure machines. The machine's basically a vacuum cleaner in reverse that you strap onto your nose and pumps air in, inflates the pharynx, and keeps it open at night. And that's been the treatment of choice ever since it was invented in 1982. That was an Aussie named Colin Sullivan out there that invented that. And so that works, and it still works. That's still the #1 prescribed treatment. There's been a few changes in the technology since then, but that's still the #1 treatment. There's surgery that's done occasionally. Oral appliances kind of belong second to CPAP. You really don't want to go to surgery until you've tried the non-invasive things first
Right.
in patients.
And so the CPAP is the one. I was flying to a lecture the other day, and I saw somebody take out a box in the security line. I guess you can't just x-ray this in your luggage, and they had to take it out and bring all this thing out. And it looked like a machine, I guess, about the size of this, with a mask that straps onto your head.
Right, and you're not signing up to be the co-pilot. That's a CPAP machine.
Right.
That, and they're cumbersome to travel with. I have lots of patients that get an oral appliance just for traveling. They like their CPAP, they use it at home, but that's just one application of having an oral appliance for a patient.
I sleep on my stomach, so it doesn't look to me like there might be a way that I could actually wear a CPAP. So if I had a snoring problem, and I actually cured my own snoring, or maybe I had a sleep apnea problem, I lost 65 pounds a couple of years ago and it stopped. So we'll get to how weight loss fits into this later. But it does sound like, for me, somebody who sleeps on their stomach and wouldn't be able to wear a mask or tolerate a mask, that an oral appliance might be the way to go.
Yeah, exactly. And at least half the patients that start pressure therapy with the machines abandon that down the road. Most of them pretty quickly, and then a lot of them later down the road. And so there's a huge demand for oral appliances for those patients. If you only made appliances for patients that couldn't wear CPAP, that had already been diagnosed, and you had a relationship with a physician, a sleep doc, or a pulmonologist, someone that prescribed those, if you only treated those patients, you'd have tons of patients to treat. There are so many of them.
So in a perfect world, everybody would be able to tolerate CPAP and wear it, and it keeps your airway open and does all these great things. But the reality is a lot of people can't handle this and need some sort of alternative, and it turns out that dentists can fabricate these appliances and give them some help.
Yeah, that's right, and there's lots of patients that need help. You know, I'm a CPAP fan. I mean, it's the #1 treatment. It's the most robust and effective treatment out there, and I'm all for it. You know, the worst thing you can do is not be a PAP fan in terms of your relationship with the physicians.
Right.
You're a PAP fan first, and then oral appliances, you're there to help out those patients that can't use it.
Right. So this is a field of dentistry where you are, by definition, going to have some interaction with some local medical personnel, some local doctors. It's not, well, it's kind of like, you know, the way that we have a relationship with an oral surgeon or an endodontist, although we decide, you know, when we're going to send that out. But because this is truly a medical condition, it sounds like, as opposed to a dental condition, it sounds like you're going to need to have relationships with some of the sleep doctors in your community.
Yeah, and it's a little bit outside the comfort zone for a dentist. I mean, we know how to relate to specialists within dentistry. Really, it's easy to develop a relationship with a physician, and they want that relationship too. But you have to step outside your comfort zone a little bit and go meet the doctors and talk to them. But the point is that they are looking for us to help their patients as well. And if you can establish a relationship, you're going to have lots of business for oral appliances that way. Any
idea if physicians, while in medical school, do they see a lot of this? Are they educated about obstructive sleep apnea? Or?
What I've heard is that there's very little training in sleep for medical students. Basically, you graduate medical school, you go through your residency, and then finally when you begin to specialize, and usually pulmonologists, you know, breathing, all that, then you begin to specialize in sleep. So there really aren't a ton of sleep specialists out there. In LA, San Diego, there's lots of them, but there really aren't a lot of sleep labs in rural zones. And then you have to team up with a primary care doc. They all understand sleep apnea. It's so prevalent now and so dangerous. But it is a medical disorder, so the dentist has to put on a physician hat, if you will, and understand the medical part of that a little bit to do the treatment effectively. And of course, it's reimbursed through medical insurance. And so it's another example of that might be the maxillofacial prosthodontist, restoring cancer, lost a nose or ear or some structure. So really, you're doing a medical treatment for that patient too. And dentistry crosses over in medicine a lot, and we really shouldn't be separated as we've always been.
Right.
I think we're just a specialty within medicine.
Because it's really unfortunate that you've got all these patients falling through that crack, like your dad, who's not getting treated by maybe his primary care physician or his dentist, because neither group has really been educated about it. And so you got this large group of people who are suffering with something that sounds like a chronic progressive disease, a little bit like periodontal disease, where it tends to get worse as time goes on, and no one's really stepping up to help these patients. And I know a friend of mine who's a consultant whose brother died from sleep apnea. I mean, people do die from this, right?
They do. Yeah, you're right. Sleep apnea is a progressive chronic disease, just like diabetes, periodontal disease. It will worsen with time and with age. There are exacerbating factors like obesity, other things that add to the problem. But you're really treating a chronic disease, and the patient needs to be managed, just like periodontal disease. You see the patient every once in a while, clean their teeth, do all that. Well, you need to follow these patients along too. And most of them fall into treatment, they do very well, and they just need to be checked periodically. And that's really part of the responsibility you're taking on. It's not, here's your appliance, goodbye. And there is reimbursement for all that follow-up. It's not like you're not able to charge, for example, to follow the patient and take care of them along the way. And you're really partners with the physician in that role. You and the physician are partners following this patient through time and managing their disease. You're seldom curing the disease.
Right. Well, you don't cure periodontal disease, do you? I mean, you manage it and try to keep the teeth in the patient's head until they
You might have been a cure
die.
with your weight loss, though, for example, or surgery can cure a patient with sleep apnea. But oral appliances are a treatment, ongoing treatment like CPAP is.
Right, okay, that makes a lot of sense. So when you get a patient, well, if you look at the laboratory, if you look at what we do, we've made over 70,000 silent night appliances. A lot of them have been for single doctors. Well, we made one of them, and they haven't done another one since. And yes, that's always been our feeling. When you pull up the prescription, the doctor's name and the patient's name are exactly the same. And so you realize the wife has threatened maybe to leave the bedroom or the house or the marriage if the dentist didn't make a silent night for themselves. So I think one of the things that dentistry has done is that a lot of our dentists look at snoring as something that's just kind of an annoyance and not a big deal, and almost something that society makes jokes about. And then you have sleep apnea, this chronic progressive disease that can lead to death and stroke and high blood pressure and all this other stuff. But we can tell just by the number of appliances that we've made, the number of snoring appliances we make here versus the sleep apnea ones, that most dentists are kind of focused on that. And that the treatment of the snoring probably doesn't seem like real dentistry or the ability to really have an impact on a patient's life, whereas the apnea is more important. So right before we talk about how you bring a new patient into your practice and differentiate what they have, talk a little bit about the difference. You mentioned your dad already and just the huge change in his quality of life. What do you see for most of these sleep apnea patients when you make an oral appliance for them and they start to experience, being able to breathe throughout the night?
Sure. Breathing is cool. If we back up just for a second and we talk about the dentist trying an appliance on themselves, treating a dentist with an oral appliance, they're the worst patients.
Really?
As soon as you try it in and your bite feels off in the morning for a little while, it's like you freak out.
Right.
So don't try it on yourself, first. But back to your point, I tell people that ask me, dentists that ask me, this is one of the most rewarding things I've ever done. I spent my early years lifeguarding in San Diego on the beaches and literally saving lives, and that was very cool. Fortunate to do that, and now I'm doing it again, literally saving lives by getting people treated for sleep apnea. Their breathing, the significant comorbidities that take place when you strain the heart at night, and every time you have an apnea, that adrenaline surging through your body, racing your heart, raising your blood pressure, all those things are going on. I mean, you're supposed to rest when you sleep.
Right.
And with this marathon going on, that's the connection to heart attack and stroke, right? So you are literally saving a life if you treat sleep apnea. Now, you can argue some people will just snore and it's kind of benign, and if you live to be 65, you probably outlive the chance to die from that. And you won't see death certificates say dead from sleep apnea. You're going to see it say heart attack or stroke. And when do most of those happen? It's in the early morning hours when we're in that deep sleep.
Right.
We're having the most apnea, and that's when you have the heart attack, right? So it is a deadly disease for sure.
But if there was another line that said heart attack, and then there was a line that said as a result of, you might see it then as a contributing factor that actually took place. But we all, as general dentists, love when you put veneers in someone's mouth and they look in the mirror and they cry. I've had that happen recently, not because they look good, oddly enough, because they didn't look good. But when you've really changed somebody, we did a veneer case recently, and it was a guy, and he was a soft-spoken guy who works here in the building. And when he came to thank me for it, he had tears in his eyes, and it was his birthday, so this was his birthday present. But his smile, people commented to me, say, I never realized that his smile was bad. And I don't know that it was bad or what bad means, but he's been staring at it every day in the mirror and in his rear view mirror, and this was a huge change for him. I would expect that if you're able to treat patients who have the type of response that your dad did, that you would see some of the same type of response from these oral appliance patients.
And we do, and I take that very seriously. When patients come in, and I'm starting to well up now thinking about some of the patients that are so grateful that they have their lives back. They have not just the energy to have their lives go the way they would like. Spouses are happy, their marriages are saved. Literally, people sleep in different rooms and different beds because of snoring and issues like that. And if you can bring them together again, it's a cool thing to do. I mean, they're very, very grateful. And I can't do veneers like you can, but there were a few like that I had, and I see this routinely in patients. They're very grateful, very grateful.
And I know that one of the symptoms of obstructive sleep apnea is daytime sleepiness. And so you've got to think that there's a lot of drowsy drivers out there on the road with undiagnosed sleep apnea who, if you're able to get an appliance or a CPAP and help them, I mean, you're saving lives just through accident prevention in a case like that.
That's right. If you look at Department of Transportation statistics, drowsy drivers cause a lot of crashes and deaths. It's a big deal. And the DOT has a program where they have to test all the drivers, get them into treatment. I mean, just that population is a huge number of oral appliances. They actually have rigs now that can run a alternating current enough to power a CPAP, and they've got that worked out. But oral appliances for sure in that field.
I really can't stress enough what a rewarding field getting into obstructive sleep apnea and its treatment is. It really is fantastic. And again, you really are changing patients' lives. And I've seen more patients cry, men, I'm talking, not even women, but usually the men who you're treating who will come up with tears in their eyes and say things like, I didn't know if I was going to make it to see my 2 daughters get married, or I was falling asleep on the way home every day, and I didn't know if I was going to be able to provide for my family because I kept thinking I was going to die in a car accident. They're very emotionally moved when they're starting to sleep through the night, and they say things like, I forgot what it felt like to actually feel good. So a very, very rewarding little niche of dentistry that most of us were never exposed to. You can look at an organization like the American Academy of Dental Sleep Medicine, their website, aadsm.org, aadsm.org, a great way to start getting trained for obstructive sleep apnea and its treatment and the different appliances that go with it. And really, I can't stress that enough. It's a great way to be able to add an area of dentistry that you previously weren't doing that aren't back-breaking. And if you have posture issues and you're having trouble working at the chair, a great way to be able to not have to do quite so much of that, but still really be able to help patients, and in certain cases, even save lives, which we don't get to say all that often in dentistry. Well, thanks a lot for watching. On behalf of myself, everybody here at the lab, and the CSL crew, I want to thank you for your time and your continued commitment to quality dentistry.